Hello everyone. Today I came up with again a new clinical scenario. It's the case of neurology OPD department. Let's discuss the case. Topic for today is CNS infection in immunocompetent host. Means the patient is immunocompetent, and in that patient we are going to discuss about the various CNS infection. Let's start. Suppose our patient has fever along with headache. Fever, headache patient described. With this finding, what other diagnosis we will lead to that this chief complaint, fever and a headache. Suppose this patient has fever, headaches along with fever, headache has been present. Along with there is the symptoms like meningitis symptoms, nuchal rigidity, photophobia, altered mental status. That's like a meningitis symptoms. Similarly, there is another aspect in that the patient presents with the general paresis, which affecting the cortex, like personality change, dysarthria, difficulty in speaking, dysarthria, personality change. Similarly, symptoms like dysarthria, personality change. I'm going to forget that what's done. Dysarthria, personality change. That's okay. No? That's the symptoms of general paresis. General paresis symptoms. Along with there is the Argyll Robertson pupil. Special finding that is the Argyll Robertson pupil is present. Similarly, there is another new finding that is the Tapes dorsalis. In Tapes dorsalis, it is the huge collection of symptoms. That symptoms it was the sensory ataxia. Sensory ataxia has been present in the patient. Along with sensory ataxia, there will be the deep tendon reflex has been performed, and that will be decrease and pain. Typical three symptoms in collection belongs to the Tapes dorsalis: decreased deep tendon reflex, sensory ataxia, and along with there is one new symptom that is the sensory ataxia, deep tendon reflex decrease, and the pain, that is the Tapes dorsalis. Now discuss with this finding. I have sent the lab. That lab is what that lab sent, that is the VDRL RPR. VDRL RPR has been sent lab, serum or fluid, from the serum blood, from the blood smear or serum or CSF fluid. VDRL RPR done, that is the rapid diagnosis, or it is also used in the screening. That comes to be positive. Along with fluorescent treponemal antibody absorption test has been sent to the lab, and that confirmed the diagnosis. With all these findings, the diagnosis will be for this case is neurosyphilis. Let's talk more about the neurosyphilis. There are two categories of neurosyphilis. First of all, let me clear one point, that is the neurosyphilis can be present without fever and headache. If there will be no, it is not mandatory that the fever and headache must be present in the neurosyphilis. So that must come to the, that must be kept in the mind before the backup to keep to come to the or conclude the diagnosis of neurosyphilis, that should be taken. And typical, if patient present with the meningitis symptoms like altered mental status, photophobia, neck nuchal rigidity, is these are the findings present. That is the in early neurosyphilis, this finding will be present. Similarly, there is another scenario, that is the late neurosyphilis. In late neurosyphilis, what will you see? The general paresis symptoms like dysarthria. Dysarthria means difficulty in speaking, personality change, and with this there will be the Tapes dorsalis. Typically, Tapes dorsalis means sensory ataxia, deep tendon reflex will be decreased. Sensory ataxia, deep tendon reflex will be decreased, and pain. That's the Tapes dorsalis. Along with Argyll Robertson pupil. These are all finding Tapes dorsalis, Argyll Robertson pupil, and that one is the sensor, that is the general paresis, which involves the cortex, that is the dysarthria, personality change. These findings will be present in late neurosyphilis. There is in difficult diagnosis will be difficult in the late neurosyphilis. Early neurosyphilis, RPR, VDRL will be positive. That's the normal, है ना? But in case of late neurosyphilis, there will be negative report of RPR testing or VDRL. So to confirm the diagnosis in late neurosyphilis, we have to order the investigation, that is the treponema test, that is the fluorescence treponema antibody absorption test. Then that will confirm the diagnosis of late neurosyphilis or early neurosyphilis. Overall, it is the case of neurosyphilis. Now, how will you manage the case of neurosyphilis? That's the important question. For management of neurosyphilis, we have to give IV, which drug? IV drug to be given, that is the aqueous crystalline penicillin G. Which drug? It's a full that is the given to in this form. Penicillin G is given, that is the normal, but which penicillin? Crystalline penicillin in aqueous form. Penicillin G crystalline in aqueous form to be given IV for the management of neurosyphilis. That's it. We are going to manage the, that's the, then follow up regularly. That's the case of neurosyphilis. Now come to the next. Suppose this patient, a new patient. That patient is fever, headache, along with focal neurological deficit. Fever, headache, along with focal neurological deficit. Patient present. What will you do? First of all, if any patient there is a focal neurological deficit, we have to immediately start with the CT scan of the head. CT head should be ordered. Then in CT head report, what shows that in CT head report there is a mass in the brain. There is a mass, and that mass is shown in the, and that has been reported by the radiologist, and that shows that there is a mass. Now comes to the two diagnoses. In mind, there should be two diagnoses. That is the one is the neurocystic sarcosis or brain abscess. How will you differentiate the diagnosis between the neurocystic sarcosis or brain abscess? First of all, the mass, that is the radiologist what said that there is the brain mass, that is the ring enhancing lesion. The lesion in the brain, that is the ring enhancing. So how will you differentiate that whether it's the neurocystic sarcosis or that is the brain abscess? First of all, from the history, patient typical history shows if patient residing or recent travel to the South America, Central America, Sub-Sahara Africa, and Asia. If these four places patient has recently visited, that means the clear-cut case of neurocystic sarcosis. That's it. If that is the case of neurocystic sarcosis, if that finding of neurocystic sarcosis, that history is absent, there is no travel to the Central America, South America, Sub-Saharan Africa, and Asia. If these 8 regions there is no history of travel, then that will be the case of brain abscess. But in typical brain abscess, there will be the history of it most commonly spread from the dental abscess. Maybe recently neurosurgery has been done, trauma or neurosurgery has been done to the brain. Or recent there is one typical, that is the blood infection. From the blood, that bacteria went to the brain and abscess has been formed. So how will you manage the case of brain abscess or neurocystic sarcosis? For management of brain abscess, we have to give IV antibiotic, plus we have to drain that abscess, plus minus steroid, corticosteroid, plus minus can be given. But it will be good to prescribe steroid, that will be helpful. Inflammation has been reduced. Okay, done. Now, how will you manage the case of, that is the case of what? Now, next question, how will you manage the case of neurosyphilis? That's neurosyphilis. For the management of neurosyphilis, we have to give albendazole plus prednisone plus minus anti-seizure medication. Sometimes there will be seizure, so plus minus anti-seizure medication to be given to the patient. So that this patient also manage. Now come to the next patient. This patient says that again fever, headache. Fever, headache has been chief complaint of the patient. Now we have to see the patient whether the patient is no, that's the fever, headache, that's the symptoms. Along with there is the extra symptom, that is the extra symptom, that is the what the photophobia, nuchal rigidity, and altered mental status. With all these findings, we have to first decide whether we have to perform lumbar puncture in this patient or not. Or if lumbar puncture is not done, then what else we can do? If lumbar puncture is not possible in this case, then we have to perform the CT scan. If lumbar puncture is not possible, then we have to go CT scan. Then what is the criteria that the patient is eligible for lumbar puncture or not in this case? There is a simple mnemonic that is called the fail. Lumbar puncture fails. If that fails mnemonic uh, fits in this criteria, then we are not able to do the lumbar puncture to the patient. Criteria are focal neurological deficit, altered mental status, immunocompromised, lesion over the lumbar puncture site, and next is seizure. If any of the condition from these five points is present, then we are not able to perform the lumbar puncture test in this case. So if lumbar puncture is not done, then what else we can do? So we should not have delayed the treatment protocol. As soon as we are patient visited to the emergency bed, we should, if lumbar puncture is not possible or it has been delayed, then we should give antibiotic first, immediately, before CT scan to be done start. Okay. If lumbar puncture is not done, then CT scan to be done, and CT scan there will be the another finding, that's all. Okay, done. If suppose if our patient has criteria met that the patient can be taken for the lumbar puncture. Lumbar puncture means there is no focal neurological deficit, there is no altered mental status, there is no immunocompromised history, there is no lesion over the lumbar puncture site, and there is no history of seizure. If these five symptoms, these five criteria has not been met, all these things are ruled out, then we definitely do the lumbar puncture test before antibiotic prescription. In lumbar puncture test, what else we can do? Suppose there are different lumbar puncture findings. Suppose our one patient has said done a lumbar puncture, and that lumbar puncture report shows that more than 1000 polymorphonuclear neutrophils, glucose reduce, protein increase, and opening pressure while doing the lumbar puncture, opening pressure is increased. With all these findings, it is the typical lumbar puncture CSF finding of bacterial, not viral, bacterial meningitis. Typical bacterial meningitis has been diagnosed in this case. Okay. Now, how will you manage the case of bacterial meningitis then? Before management, first of all, little talk about this bacterial meningitis. It's the most common one. First of all, it has been causative organisms have been categorized according to the age group. Suppose there is a patient of less than 3 months. There is another group patient that is the 3 months to 50 years old patient, and there is the another patient who is more than 50 years old. Suppose our patient has less than 3 months age. What are the organisms most likely to be present? Most commonly group B streptococcus, Escherichia coli, Listeria. If these three organisms present in less than 3 months patient. Suppose our patient, another patient that is the 3 months to 50-year-olds, in that range our patient falls, then most common organism is Neisseria meningitis, Streptococcus pneumoniae, Haemophilus influenza. Neisseria meningitis is the most common. Most commonly done when number one, if we have to tick mark or diagnose, that is the Neisseria meningitis is the number one cause. How will you think that the patient is presenting with the Neisseria meningitis? For Neisseria meningitis presentation patient, there will be typical petechiae, may complicate to the Waterhouse-Friderichsen syndrome. For the prophylaxis, we can give the patient that the ciprofloxacin or rifampicin to be given to this patient for the Neisseria meningitis treatment. Suppose, okay, done. Then suppose the patient is more than 50 years old. What will the most common cause of the bacterial meningitis? Same, that Neisseria meningitis or with Listeria and Streptococcus pneumoniae most commonly will be there. Okay, according to the age group also done bacterial meningitis. Now, how will you manage the case of bacterial meningitis? For the management to the case of bacterial meningitis, I have to prescribe IV ceftriaxone plus vancomycin plus ceftriaxone, vancomycin plus steroid, that is dexamethasone plus minus ampicillin. Ampicillin to be given to the extreme of the age. Suppose our patient is less than 3 years, 3 months, no, less than 3 months and more than 50 years old. That extremes of age, we can add one extra antibiotic, that is the ampicillin to be added. That's done. That's done of the bacterial meningitis. Now let's come to the new CSF finding. Suppose the new CSF finding lumbar puncture says that the lymphocytes is about less than 250 lymphocytes, glucose normal, protein is normal or increase. There may be protein normal or increase. With this finding, this is a typical finding of viral meningitis. This is a typical finding of viral meningitis. In viral meningitis, the most common cause is like the enterovirus, herpes simplex virus. That is the most common cause of viral meningitis. How will you manage the case of viral meningitis? Simple, supportive care and IV acyclovir to be given. That's it. And then next, now suppose there is another patient that has the CSF lumbar puncture finding. What it says that in this there is the lymphocyte of about 100 to 500 lymphocytes, glucose decrease and protein increase. With this finding, this is a typical case of tubercular meningitis. Tubercular meningitis. For the tubercular meningitis, one thing should be strike to our mind, that the patient has been recently traveled to the endemic region, or there is any risk factor for the exposure to the recent TB. With all these findings, that will be the typical case of tubercular meningitis, and that CSF finding will definitely confirm the diagnosis. For management of tubercular meningitis, what I have to give? For the management of tubercular meningitis, I have to give the rifampicin, isoniazid, pyrazinamide, ethambutol plus dexamethasone to be given. That's done. Now there's the next last patient. Why should I have to wait for that patient? Let's manage that patient also. Last patient, the typical, that's the lumbar puncture finding. What lumbar puncture finding typical shows that there is the lymphocytic pleocytosis plus lymphocytic pleocytosis, xanthochromasia, protein increase, and PCR there is a herpes simplex virus positive. With all these findings, it is the diagnosis of herpes encephalitis, herpes simplex virus encephalitis. It is the case of viral encephalitis, herpes simplex virus. Suppose if this patient there is the PCR positive, then herpes simplex virus is the cause of viral encephalitis. Suppose the patient has negative herpes simplex virus, then other cause will be the Rocky Mountain spotted fever, Lyme's disease, enterovirus, toxoplasmosis, other different virus like West Nile louse. The other virus will be the cause. That's it. In how will you manage the case? No. In typical, if CT scan done, that encephalitis will be typically seen in which lobe of the brain? That is the temporal lobe, is the favorite site for herpes simplex virus encephalitis. And in CT scan, what will you see? There is the hyperdense lesion, hyperdense foci lesion in the temporal lesion. Suppose if CT scan shows indeterminate result, and we are highly suspicious for the patient to be we are highly suspicious that the patient has definitely the herpes simplex virus encephalitis, then we can order the further investigation like MRI. That MRI will definitely diagnose the case of herpes simplex virus encephalitis. it's all done. That list, there is a one point that I'm missing, that the in bacterial meningitis there is a extra add-on point, that is the suppose patient has the rash, then we should think about the if Borrelia burgdorferi, then Lyme's disease will be. And similarly there is the Rocky Mountain spotted fever, that will be the cause of rickettsia. Hope all this done. Hope this will have helped you to get the insights regarding the CNS infection in immunocompetent hosts. Thank you, everyone.